called Health Workforce Policy of Migration. It's a policy of managed migration. It has a forward, the background, the various chapters, all that I've laid out for you, including those who have been consulted in development of this policy up to its approval. On the ministry's website, we're streamlining because it's a large document, so it is easily downloadable, but it's available document and has gone through iterations of consultations with key actors, with key professional bodies, with health workers from all across the country, as well as other ministries. And it's, on one hand, focuses on health, but it's connected to wider effort of the Nigerian government to deal with the problem of migrations, how we harness this potential as a country that has a lot of youth, some of whom are in school, are learning, and they have high aspirations. We think we're the country of the future. How do we harness this demographic potential? I think you'll find that almost 17,000 have been trained over the last 5 years. More than half of them have left. So the younger doctors tend to be trained and they leave because there's demand elsewhere. They want to be better trained and they see the challenges that we face as a country. So this policy is to try to address that so that we retain, provide the services that Nigerians need, while in a way making it easier for those who have gone to be able to come back. And over time, for our health system to be one that in a way provides less push for them to leave, despite the pool that they have from the more advanced countries.
Well, the minister has asked Nigerians to take a look at that policy, and that's exactly what we're doing. We're breaking it down for you. What exactly is this national policy on health workforce migration in Nigeria all about? Well, let's find out this morning. We're joined on the program by the National President, Association of Medical Laboratory Scientists of Nigeria, public health policy analyst. He holds a PhD in molecular microbiology and a fellow West Africa Postgraduate College of Medical Laboratory Science. Dr. Kasmir Ifeanyi is right here in our Abuja studio. Good morning, Dr. Ifeanyi.
Friday, good morning. How are you?
And joining us via Zoom is Dr. Emeka Orji, a former national president of the Nigerian Association of Resident Doctors. He joins us from Enugu. You're welcome to the program, Dr. Orji.
Thank you for having me.
What we're doing essentially is to take a cursory look at this new policy. When a lot of people hear about the health workforce, they think about doctors alone, but the health workforce is all encompassing. You have not just doctors, nurses, midwives, you have medical and laboratory scientists, you have physiotherapists, and so much more. So we're trying to bring at least some of the angles to this particular matter. But since the minister said, let's take a look at that policy first, let's just do that. Now, this policy focuses on some key areas, issues like incentives, health workers' safety capacity development, strengthening health workforce education and training, health diplomacy, ethical recruitment and equality. Also touches on research, innovation and strategy, as well as governance and leadership, of course, monitoring and evaluation. But let's keep to the big one, the elephant in the room, which is incentive. That is at the heart of this JAPA situation. Now, some of the issues laid out in that policy, which we'll be breaking down, is periodic review of healthcare workers' salaries, benefits, pensions, and allowances. That's on the one hand. Then federal and state governments will develop a special incentive program for all health workforce serving in rural and underserved areas, as well as easy access to special credit facilities, tax holidays, and all other issues regarding incentives. There's also talk about equipment and the rest. But that's just to give you a sense of what the government is thinking regarding incentive, which is a big one. So let me start from Dr. Ifeanyi here in our Abuja studio. I know you'll have gone through that. You know, health workers are big on documents and going through the letters. What was your immediate reaction to the policy?
Good document, quality document, but there are lots and lots of gaps. And for me, the document is good, but it remains work in progress because very many details are not contained therein. The work condition, what we call conditions of service, are not contained in that policy. They are available at the service points, at the facilities. So how will this policy document dovetail into extant conditions of service. Now, that document also, I took time in the night. It's about 56-page document. I took time to browse it, and I discovered that there are areas of weaknesses. And in your intro this morning, you harped on some of them. If they have passed the ball to state governments to to implement aspects of the policy, and it is left for them to implement if they think they have the resources, we are going to have issues. Now, the point need to be made clearly. You talked about the big elephant in the room, incentives. In that policy document, the incentives are not clarified. The point need to be made, we need to have a backdrop. Why are Nigerians living in droughts? Particularly healthcare workers, healthcare professionals. Why are they leaving? Where are they going to? What is the difference? Can we contrast effectively the reason that where they go to is supportive, is receptive, whereas in country they have the urge to just leave, Last week I had a need to refer someone to see a gastroenterologist, a consultant. And I thought in Abuja, being a mega city, you will have them in their numbers. The last places I knew we had some. I reached out to them and I realized that at that top level of care, that top level of specialty, that they are all going. So there's something that is not keeping them here. And let me make a clear-cut analysis. Right. If you go to the UK as a consultant and you're able to earn, for instance, £6,000, I'm being very conservative here, per month, and you stay in Nigeria and you don't earn as much as 1.5 million. 1.5 million is less than 1,500 pounds. Yeah. So what will force you to remain here? In fact, 1.5 million is in the neighborhood of 500 to 700 pounds. So why would you want to stay here? Now, when you stay here and you work, you are not safe. Healthcare workers, healthcare professionals are prey to kidnappers. Sometimes they are just assassinated. So there are more to the policy document that will help indeed retain. The intention, the objective of this document is to retain our best hands here in country, doctors, nurses, medical laboratory scientists, to care for our people. We feel that we train them and they are poached, they are taken away, and so the resources expended by the nation training them is somewhat lost. Right. It's not entirely lost. I think that this document should have factored what I consider the brain gain. Today, with the data showed on your slide, we have very many doctors in different parts of the world. Many of them had gone on to acquire cutting-edge skills and knowledge that are not commonplace in Nigeria. So what are we doing to see if we can indeed reverse this incentive to bring them to come home?
And I think the document also speaks on issues of diplomacy, ensuring that there's adequate data that they can tap into. In fact, the document compares Nigeria to India, saying that there are lots of Indians out there, but the difference between Nigeria and India is India has data, so they're able to leverage on those numbers and then, of course, bring that technology back home. In fact, I looked through figures of medical laboratory scientists leaving the country. In fact, it's in that document, and it's quite interesting how the document breaks it down. In total, for the years 2021, let me do 2022. 2022, you had 1,553 leaving the country in total. But then...
That's underreported.
That's underreported for you. There you go.
And I'll tell you why. They sourced this data from agencies of government.
Right.
In sourcing data about exodus of healthcare professionals, I expect that government should bring in professional associations who have real-time data on their members that are leaving.
So you think MLSEN doesn't have adequate data?
That's agency of government for regulation, so they wouldn't. We deal with the welfare of our members, so we know when our members die, we know when they give birth, we know when they leave, we know when they marry.
Before they leave,
we have more data.
Before they leave,
migration.
Don't they get letters of good standing and all of that?
Now, many of them who leave go there not even to work in laboratories, for instance. So, and if they do, they ask us to give letters of good standing. It is actually the association that give letters of good standing. All they require from the council is license to practice.
Right.
Most times, the license they have here, when they go abroad, they will require to do some kind of training.
So you think it's double this figure?
Oh, it's a lot more. In fact, this number of 1,000 for that year is just about the number that left in the FCT.
Oh dear. Let's go to Dr. Orji. He has painted that picture, particularly the fact that he thinks this is not specific enough for incentives. It's beautiful, he says, but it's not specific enough for him. Dr. Orji, do you share those sentiments?
Well, I want to start by commending the federal government of Nigeria, particularly the Honorable Minister of Health, for coming up with a policy that is aimed at reducing or even reversing the brain drain we currently have in the health sector. Knowing the minister and having interacted with him on different occasions, I'm convinced that he has what it takes to turn around the fortunes in the health sector. However, just like my co-guest has said, I have a problem with the details in that is lacking in that document. And I will also say that we've made this point over and over again, even when I was the president of NAT, that in addressing the issue of brain drain in the health sector, the government should not just on their own come up with a policy without involving the unions and associations in the health sector. Because ultimately, we are the ones on ground. We are the ones interacting with these members directly. We know exactly why they are leaving. And so if you, as a government, decide to come up with something like this without consulting the Nigerian Medical Association, with their affiliates, the other health sector unions, it will be difficult for you to come up with a document that will address the root causes of brain drain. You have talked about incentives. What are the details? Because we know that no matter what anybody says, that is the main reason why people are leaving. And so if you do not address that, I find it difficult to believe that any other policy will work. We also have a very important issue, which is the ravaging insecurity in this country. And unfortunately, it looks as if doctors and health workers are now the main target. As we are talking, we have a resident doctor in Kaduna, a female for that matter, Dr. Ganiat Bobola, who has been with the kidnappers over the past 7 months. And I'm sure if you've been listening to me, you will know that even the Nigerian Association of Resident Doctors is threatening to go on strike on that matter. And so, a host of other kidnapping incidents affecting doctors and other health workers. So the government has got to involve the unions and the associations before you come up with a policy like this. Otherwise, I doubt that you are going to address the root causes of brain drain in the health sector. This incentive that is being talked about, what is the details? You say you want to regularly review the wages of doctors and health workers. The recent review that was done, what was it based on? The one that was done last year. The government just offered a percentage, which is not even enough to even restore the value of the salary as at 10 years ago. And so when you keep doing this and you keep looking at other issues without addressing the root cause, which is poor remuneration, it is not going to work. And I also have a feeling, because I glanced through that document, I think I saw a place where the government talked about bonding, where they talked about things that made it look as if there is also a renewed attempt, to restrict the movement of health workers outside the country forcefully. And so if you are looking in that direction, it means that you are totally going off the track, and you are going to worsen what you are trying to prevent. So we are waiting to see the details, and I don't think it is late. The government can still sit down with the unions and the associations in the health to at least try to explain in details. Maybe there are things that are not contained in that document, that they may want to explain to us. Let's get to know how the implementation of this policy will work, and then get inputs from them before we can move forward.
Again, because you started by saying you have some faith in the health ministry, which brings me to this question of, it's not just about creating policies. They say the success of any development is in its implementation and, of course, its impact on the people. So looking at what Nigeria has been, maybe the history on implementation and policies and how it has worked over the years in this country, in every sector, not just the health sector, do you still have faith in the health ministry that this can be achieved, that when they call them back, they will be able to give them the deal? I mean, this is like a deal. You say, come back because we have this. So when we come back and you do not provide us with that, what then happens?
And so it goes back to what I have said before. What are the processes? How do you intend to implement this? I have told you that, in fact, scientifically speaking, because when I was the president of NAT, we did studies, because we are also worried about the brain drain in the health sector. Is even affecting us more, because I mean, in a particular unit that you are supposed to have 10 doctors and you have one, it simply means that the person will be overburdened by work. And so it is leading to breakdown, people having a burnout syndrome. So on our own, we did a study to find out the major cause of brain drain in the health sector. And the number one cause is poor remuneration. Government has not been able to address. So if you don't address it, people will keep living. And so how do you intend to bring back those who have left? What exactly are they coming back to live on? Because the economic situation is biting harder, and unfortunately, the economic policies of government in the last 1 year has even worsened the condition we are talking about. And so I want to repeat that the government should sit down with the associations. Let us discuss this and then come up with a workable plan on how to improve our fortunes in the health sector. By the way, let's not make any mistake of thinking that the Nigerian health workers are asking to be paid exactly what is paid outside the country. That is not what we are asking for, because we know what means that the government cannot afford it. What we are simply asking for is a living wage, something that will be based on statistics. The percentage increment that was given last year was not based on anything. And what we have been asking for is salary restoration. What is the value of our salary? When compared to 2014, like 10 years ago. And so what percentage increment we restore the value of that money? That's what everybody has been asking for. And you are aware that we brought out percentages last year. We brought out 300%. Eventually, when fuel subsidy was removed, and the dollar was floated, the indices changed. So government has got to put all this into consideration, before you talk, because if you are addressing other things, you are not addressing this remuneration issue. I believe strongly that the brain drain in the health sector will not be addressed.
Let's take it to Dr. Kashmir in our Abuja studio. Doctor, I've been listening to some of the things that have been said, and let's put some specifics to it. I'm trying to get all my documents correct now. Dr. Ifeanyi, let's put some specifics. So, like Dr. Kashmir has said, Dr. Oji has said, he talked about the fact that you're not expecting them to match up the amount. You mentioned £6,000 or so, and Nigerian payments. I don't know how much the least doctor earns. I don't know how much a consultant earns. Yeah, maybe you can give us that figure so the audience will begin to examine for themselves and know whether this is a workable document. But there are two concerns I want you to speak to first. I'm wondering why the health ministry, from what both of you have alluded, will come up with a policy document like this, at least a direction, without consulting the association. Is it really that they didn't consult, or the consultation was not wide enough? Because some of the things you're saying is the fact that this data is underreported. 2022 was one of the highest time in migration, both for across all the sectors, in the subsectors in the health sector. So I want you to talk about that issue of engaging association or sub-association as far as collating data is concerned, because they were big on that in that document. Second is, what will be fair? Say a doctor, and I have friends who are doctors across the world, in the UK as well. If a doctor earns, say, £6,000, what will now be fair if you're calling that doctor, say, Dr. XYZ, please come back to Nigeria. We respect the fact that you chose to leave, but we need you here. What will be fair in terms of negotiation? Because we can't match up given our pulse at the moment.
Thank you very much. Like Dr. Oji said, we're not asking Nigerian government to pay equivalents of what our colleagues earn when they go out. That's impracticable in the circumstance we have in Nigeria. But there are pertinent things that we need to speak to. I'll give you an example. He had talked about the wage review that was done for doctors in Nigeria. I want to say that that wage review has not applied to other healthcare professionals, which he said was discretional, and it wasn't empirical. So something was even done, but it wasn't empirical, and it wasn't cross-cutting. So when I talk about condition of service earlier on, I can work in a place, I'm not well remunerated, but if the conditions of service are supportive for me to develop myself, to advance in my career and progress, I would like to stay for other overriding reason. But if I work in a place and it's difficult for me to get promoted when I am due for promotion in the health sector because of the cadre of staff I am or my healthcare professional background, it's a problem. If we have issues about governance, leadership, and direction at the facility points, these are not monetary terms per se. So I talk more about conditions of service. Is it supportive? Do I have a house? Where do I live? So you pay a consultant who lives in Abuja 5, 8, 700, 1 million naira. That consultant, predicated on his salary, cannot live in Wuse 2, cannot live in most parts of the phase 1 of Abuja to work. So there's a lot more to look into if we want to indeed retain the people we have here and make it attractive for those that had gone out to come. I give another example. The highest, a medical laboratory scientist that is at the directorate cadre, a director, his hazard allowance is less than 40,000. It's about 35,000 naira hazard allowance. So if you go down the rung to senior medical lab scientists, you will find out that what they get as hazard will be around 15, 17,000. It used to actually be a pantry sum of 5,000 naira for all the hazard they take. I want to shock you that more than 95% of Nigerian healthcare workers, healthcare professionals particularly, do not have indemnity. They do not have insurance. So in this document, in this policy document, I can't find where it spoke to about providing insurance. If we have insurance, it will speak to the issues of when you are molested by patients' relatives, to speak to the issues of when your life is cut short, either by reason of security breach or other forms of threat. So that's not in place. Part of why people leave is that they are beginning to feel a lot more insecure here. They feel that by reason of their profession, doctor, nurses, med lab scientists, that they are exposed. Other people in the society look up to them as people who they think earn enough to live well, and they had become prey. So you talked about engagement with professional association. I must say that the minister of the Honorable Coordinating Minister of Health, his doors are open. I was actually with him a couple of weeks ago, and we spoke on a whole lot of issues. But for this document, I doubt strongly the level of engagement that took place with my association and other professional associations in the health sector. Now the president had approved the document. Like Dr. Oji also suggested, I would want to suggest that the ministry should stage a workshop to step down this policy for us to discuss it. It's not cast on stone. If there are improvements, if there are modifications that can be done to the document to make it work, we are concerned that our people are leaving. But I want to say, growing up in Nigeria, I knew when we had plenty Cuban doctors in northern parts of Nigeria. I knew when we had plenty Indian doctors in southern part of Nigeria. Will they still come today? They would not. They were coming then because we had a strong economy, because our remuneration for healthcare professionals, for doctors, were quite attractive. So that's the point. We need to look at what is the missing link. We need to speak to it. The minister yesterday talked about the various lofty interventions that had come. And I consider that a translation of the renewed hope agenda to realities in the health sector. About 4 or 5 of them, laudable and commendable. And I can give it to the Honorable Coordinating Minister that he really understands his job and it's cut out for him and is going ahead to indeed take steps to see how he will be able to recover, reinvent the Nigerian health sector. That's why he started in December with the reinvestment program that was launched by Mr. President. Thereafter, the program about infrastructure and equipment in the hospitals located in the 6th geopolitical zone. Thereafter, we also had him come with the executive order on local production of diagnostics, drugs, hospital consumables, laudable interventions coming from the ministry and this particular policy. But we're saying that there are gaps in this policy and the policy should be considered work in progress and there should be more constructive engagement with professional associations to clarify on the gray areas and to remove obnoxious provisions.
All right, Dr. Fine, we hear you. Let's take it to Dr. Oji before I trade back to my colleague, Kayode. I want you to further speak, Dr. Oji, to this issue of conditional service, because he's mentioned something quite critical. When I told him to draw a comparison and maybe give us some level of markers in terms of how to woo doctors, say, from the UK back to Nigeria, and he was very clear, saying, look, it's a far cry to begin to talk about comparison in numbers, but working condition. So I want you to speak to this working condition issue, which to me and to the audience looks to be one of the major drivers why doctors are leaving, especially those in the rural areas.
Okay, so, you know, it's an important thing because we have also made these suggestions, and that's why I kept hammering on involvement of the professional associations in the health sector before any such policy is implemented. By the way, let me correct that. The salary review that was done last year was done across board. It was not just for doctors and nurses, and we have the document available. In fact, it has even been implemented. What we are talking about is that it was more of government just awarding a percentage, which is not anything to go by in terms of the statistics we have on our hands. Now, you see, this what we're asking about, we include the issue of housing, you know, the issue of cars, the issue of schools for the children of healthcare workers, the issue of training and retraining. Yes, again, to correct, that document has something on insurance for healthcare professionals, but again, there was no details. You know, how is it going to be practically implemented? Take for instance the issue of housing. Why are our doctors not accommodated within the vicinity of the tertiary health institutions? You know, build houses. Most of these tertiary health, health facilities, they have enough land to accommodate housing units for doctors and other healthcare professionals, which, by the way, government can do in form of mortgage. If you are taking it from their salary every month, just small percentage, and someone has like 5 or 10 years to pay up, I have a feeling the person will not want to leave. You know, what about the issue of cars, you know, and other amenities that can easily be accessible by these doctors and nurses? So it's about sitting down and discussing how do we incentivize these the work of these healthcare professionals so that they will have enough confidence in the system. We should not also forget the issue of infrastructural deficit in the health sector, because again, the other is also an important factor, because as a doctor, if you have your patient before you and you know what to do to help that patient, but you do not have enough infrastructure, you do not have enough equipment to take care of the patient, and the patient dies in front of you. So many doctors have gone into depression because of that. You know, and so I want to repeat, the remuneration should be taken care of the other welfare issues should be taken care of, because it's only when you do that that people will have enough confidence in the system. What about insecurity? Now, you talked about the rural areas. How many, in fact, it's not just doctors. How many people will want to go and stay in the rural areas, especially in all those isolated places without security? Has there been any effort to build or to construct these health facilities in the rural areas in a way that it will be secure, with perimeter fencing, with housing units within the premises, with security around that place? Because no matter how much you pay anybody to stay in the rural community, if the safety of the person is not guaranteed, you will simply be making that money for kidnappers. So we are asking for a holistic discussion on this thing, because that is the only way people can bring in their ideas. Government does not know it all. Government should engage the professional associations before we come up with something that is workable.
So talking about, this is to Dr. Kashmir, talking about things that is maybe something that is workable. We know that not all stakeholders were engaged in this decision or policy making and creating it. If you were to be involved and say your own part on what should be in this document, maybe contained in this document, that is workable and something that holds water, and people will see reasons why they should remain in this country and work for this country, what will be the content that you'd be advising? The real detail, not just something shallow or something just written.
You see, the healthcare industry or sector is a tapestry of professionals. And I quote succinctly the Honorable Coordinating Minister of Health yesterday evening. And if that is the case, whenever we want to make policy, whenever we want to draft condition of service, we must take cognizance of that fact and not create a situation where we have discriminatory policies or unacceptable parity in remuneration. These are issues. This discrimination extends to area of training. I give you an example. Apart from Nigerian doctors who are supported to do residency training, no other healthcare professional in Nigeria is supported to do such postgraduate training. So these are conditions that now we're discussing training, and the minister is really passionate about retraining and training of frontline health workers. We should clarify on who is the frontline health worker. If you look at the training ongoing, the target is about 120,000. The minister said they have trained about 10,000. How many of these are members of what I call and what is globally known as core clinical profession? They are basically four: the doctor, the med lab scientist, the nurse, the pharmacist. Core clinical. There can be other clinical service providers, but these are the core clinical. So in the training program that we have today, how many of the rest of the core clinical services benefit from government-funded and supported training to acquire new skills, to advance in career? These are issues. Now, these members of this profession, like pharmacists, are appointed consultants. Government releases circular appointing them consultants, and it becomes a basis for crisis. I talked about the increase, and I said it was not empirical, because I do also have documents where the commerce salary scale were serially reviewed, whereas the current salary structure was paused. So if after you have increased one salary structure 2-3 times, and you now say you are doing a review that is cross-cutting, which is even discretional, and you use your discretion, not empirical, to add money across board, it cannot be considered to be across board, because the parity gap had become wider than what it used to be. So these are some issues we need to discuss. We must free up opportunities for training and retraining, for building capacity. Healthcare is like a tripod. You cannot continue to extend one leg of the tripod. It will topple. That's why we have issues. And we're talking about Japa syndrome, exodus of healthcare workers. I want the Federal Ministry of Health to deploy the WHO Wilson to workload indicator staffing needs. So we really know who is on ground, how many doctors are on ground, how many patients do they see per year, per day, and what is the working hours. If we enter the laboratories, how many medical laboratory scientists are on ground? How many samples do they analyze? I know a tertiary hospital in Abuja where you can count in one hand the whole med lab scientists in that place. And it is like a Wuse marketplace in terms of patient volume.
Right.
So a lot needs to be done. As we speak about Japa syndrome, my young med lab scientists in Nigeria, if I provide you data on unemployed medical laboratory scientists that are roaming the streets, that are underemployed, that is unemployed, underemployed, under-remunerated, they are in large number, and they account for people who are now living. In fact, I had one who just left. They live in number. That's why I said the number from the Medical Lab Science Council of Nigeria, of course, a good data source,
right,
but it's an underreported data because the 1,000 for 2022 alone is just about the number that left between the hospitals in Federal Capital Territory administration and other adjoining hospitals in their city.
And it paints a really dire picture, really, Dr. Ifeanyi. As we begin to coast home, two things to mention. You were talking about data, and from that document as well, and part of the introductory, preamble says that what Nigeria has, at least for the doctors, is less than 1 doctor to 1,000 people. The WHO recommends at least 4+ doctors to 1,000. So that paints a picture. And it's important to get that data so we know where we're at, because some of those data are even years ago. Yes. So only God knows where we're at right now. That's on the one hand. In terms of engagement, looking through that document, and particularly last page, you see that at least 146 different organizations, associations actually, were part of that. NMA, the Association of Private Practitioners. It's interesting. I saw, your council, not the association. So the question then will be, doesn't the council also speak in some sense for all of the practitioners? Is there some sort of division? Because it's expected that if you have the council represents all of the members who are in the association.
The council is the police for the profession.
And you don't trust this police?
No, hold on. The police is agent of government for enforcement, for regulation, enforcement of compliance. So if you think that engaging with the Medical and Dental Council of Nigeria will suffice, and you therefore do not want to engage the Nigerian Medical Association.
Medical and Laboratory Science
Yes, I'm
Council.
giving you an example. Okay. So the point I'm making is that we must know that councils are agents of government, they're MDAs of government, and they cannot speak in terms of the welfare of practitioners. It is their professional associations and union that can really speak on the welfare and the real-time conditions of their members. Having said that, you just reminded me of councils. In this wonderful document that we have, and we all commend it, I hope you know that this year's budget for health is 5.21%. It has not dwarfed what it used to be since the return of democracy. We expect that these lofty ideas will come with a budgetary provision for the health sector that should dwarf what it has been, right, that should go up to support these provisions. I also want to remind you, one of the good things that the Honorable Coordinating Minister had done is that there was this policy of government to remove the regulatory councils you mentioned from budget line. The minister provided explanation and justified it. I will commend President Bola Ahmed Tinubu for restoring them into the budget line. Right. But 8 months down the line, workers in the 14 regulatory agencies, Medical Laboratory Science Council of Nigeria, Medical and Dental Council of Nigeria, Pharmaceutical Council of Nigeria, the list is 14. They are yet to be paid salaries. So how will that police what we do? Well,
Dr. Ifeanyi, you've always heard that police is your friend, but I don't know what's going on in this case. But let's begin to wind down. Dr. Orji, it looks like both of you agree in terms of the fact that this document can be better. It is good, but it can be better in terms of more engagement. And I wonder what that would look like, and specificity. At the heart of this is really money and funds. But you people disagree on that increase. You say that it looked like it was across board. Dr. Ifeanyi says, well, no, he mentioned the CONMES and CONHES for the average Nigerian, they might not understand, and they're wondering, what is the way forward? That is what the average Nigerian wants. They want to be able to go to the hospital and get the care that they deserve and desire. So as your final thoughts, really, what will be the way forward for you? We know at the heart of this is money. The document says federal, state, local, and even the private sector must be involved in all of this. So final words for you, Dr. Orji.
Thank you very much. I've actually made effort not to dwell in areas of disagreement between doctors and other healthcare.
We can disagree to agree, Dr. Orji. It's okay.
They deliberate, but it's in the public domain that the salary review, 25% and 35%, that was done last year by the National Salaries, Incomes and Wages Commission, cut across board. What the other healthcare workers have been asking for over the years is to erode what we call relativity in the health sector, and that is a very long discussion that I do not want to go into now. In concluding, I want to also renew my commendation for the government, particularly the Minister of Health, because at least now we have gone from the days of government feigning ignorance of the Japa syndrome. So now where the government has now realized the crippling effect of the mass exodus of doctors and healthcare workers, and they are even attempting to do something about it. The only thing personally I'm quarreling with is the manner in which this document was produced. I do not have any information that there was an extensive engagement of the Nigerian Medical Association and its affiliate, and indeed other healthcare workers before this was produced. Because if that was done, I believe that the attention of government would have been drawn to the very vital, salient issues that we believe strongly are the drivers of this brain drain in the health sector. And you talked about funding. Yes, my co-guest has also talked about it. Whatever you do and you do not meet up with even the Abuja Declaration of 2001, which effectively had Nigeria enter into an agreement to ensure that 15% of annual budgetary allocation goes to health. If you do not, release or rather budget enough to the health sector, I'm wondering where you are going to get resources to take care of all the needs in terms of the remuneration, the infrastructural needs, the personnel challenges, and the host of other things that you need to incentivize the services we render to our patients. So I want to appeal that the government should sit down with everyone to discuss this issue, and I believe that if that is done, government will come to realize what the real issues are and tackle them head on in order for us to save the health sector. What we are talking about is a serious matter.
Dr. Orji. Yeah, so, absolutely.
Thank you.
Point taken. And there are lots of Nigerians out there who want to come back, do good things in the health sector. The question again is there a policy to properly absorb them and give them that ease of business or doing business, the funding as well to do all of that? But we have to thank you, gentlemen. It's still early days. After this cursory look, we'll do a deeper dive into this to ensure that our health sector is better for it. Dr. Kasmir Ifeanyi, the National President, Association of Medical Laboratory Scientists of Nigeria, thank you so much for your time, as well as Dr. Emeka Orji, former National President of Nigeria and Association of Resident Doctors. Thank you as well.
Thank you for having me.